This program is brought to you by Emory University.
All right. Good morning, everyone. Thank you for being here. As you can see, our speaker this morning is Dr. Evan Blank. Evan's one of our second-year fellows in the clinical track, and will be talking to us today about arrhythmogenic right ventricular cardiomyopathy. Evan did his undergraduate studies at Washington University in St. Louis and medical school and residency at Mount Sinai in New York. And as you can see, like I said, he's going to talk about ARVC today. Evan.
Thanks, Dr. Williams. So Dr. Williams asked me why I'm talking about ARVC today. First of all, I want to say I have no disclosures. And this came out of a case that I saw a patient at Grady. It was a 19-year-old female that was sent to me with the chief complaint of abnormal echo. And I was, based on a lot of the referrals I get at Grady, I was kind of ready to blow it off, but then actually the case turned to be quite interesting. So it's a 19-year-old female. She had a history of intestinal malrotation and jejunal atresia with vesicular urethral reflux and biliary strictures, who had multiple transhepatic biliary drains that had been placed percutaneously at Grady. In the course of her multiple percutaneous drains being placed, she had a abdominal CAT scan which caught the bottom part of her heart and incidentally noted a dilated and thinned right ventricle. Because of that, the inpatient IR team actually had ordered a echo. I am not showing the Grady echo images since they're not the best, but we'll take a look at the echo images when she actually wound up getting an echo at Emory. But the report at least said that she had an EF of 50 to 55%, mild RV dilatation with mild to moderately reduced RV function, and some trace AI and trace TR. Taking her history from her, she basically denied pan review of systems, had no chest pain, palpitation, lower extremity edema, anything to suggest heart failure or syncope or pre-syncope. Getting some of this cardiac history was a little bit difficult from her since she was quite inactive. She had a very low activity level, not due to any particular symptom that she could kind of pinpoint, but just because she kind of said that she was a couch potato. But she said that kind of as she had her most recent biliary drain placed, that she had some fatigue walking upstairs and wasn't exactly sure or hadn't really spoken to anyone about it. In terms of her pathological history, it's kind of as I noted, she had this malrotation, jejunal atresia, and this painless jaundice, which had been relieved with biliary stents for her benign biliary strictures. In terms of her birth history, which I'm not so accustomed to taking in the adult cardiac clinic, she had a normal, uncomplicated vaginal delivery born at 32 weeks. Other than the congenital diseases that I noted above, there was no note of congenital cardiac disease in her or really anyone in her family. She denied any history of heart failure or sudden cardiac death in herself or in her family. Socially, she had graduated high school, worked locally as a cashier, and really denied any toxic habits. On exam, her heart rate was 74, blood pressure 118 over 72. Her JVP was noted to be elevated about estimated 15 centimeters of mercury. She had a 1+ parasternal heave and a widely split S2. And this happened to be exactly the day in clinic after Dr. Williams had given a talk about cardiac exam, so I found that to be helpful. And a 2 out of 6 systolic murmur at the left lower sternal base border. She was warm in her extremities and had no edema to speak of. Then we got her EKG, which also was a little interesting. So we see some Q waves in the inferior leads. And then what kind of struck my attention the most was these T-wave inversions from V1 all the way out to V4. This is her echo from Emory, and we'll talk a little bit more about it, but just to kind of get a general sense, we can see that her echo at Emory, actually, her left ventricular function was read to be at 40 to 45%, but most notably, her right ventricular function seems to be at least moderately reduced to severely reduced, and her right ventricle is larger than her left. We can really appreciate that on the parasternal short axis. We'll take a look at some more images later. So after that, I sent her for an MRI at Grady, even before I had the Emory echo images. And as we can see here, I'd like to thank Tony Smith and for helping with some of these images. We can see that the right ventricle seems to be quite enlarged, and we can see some amount of wall motion abnormality. looking in the short axis stack as well, we can see that the RV is quite impressive. Also noted was that there was some concern for LV non-compaction. In case you guys aren't familiar with reading MRIs all day, as I am not, the actual formal read was that both ventricles had impaired function, notably the right ventricle, and severe hypokinesis of the mid-cavity level of the right ventricle with apical segment and apex hypokinesis, along with an elevated right ventricular end diastolic volume to BSA ratio, and impaired right ventricular function with the RVF being read as 30%. And the report itself said that this can be seen in ARVD with involvement as well of the left ventricle. Additionally, which I won't touch on too much today, is that there was prominent trabeculation of the left ventricle with concern for possible left ventricular non-compaction. So today we'll talk a little bit about understanding the pathophysiology of ARVC, reviewing the ARVC diagnostic criteria and kind of how it helps us understand the disease itself, and describe the current guidelines for treatment and risk stratification. Just kind of as an overview, arrhythmogenic right ventricular cardiomyopathy is also known as ARVD, so ARVC and ARVD, and I'll talk about kind of why this has been the change and why it's still kind of a source of confusion. As we know it now, it's a heritable cardiomyopathy that predominantly affects the right ventricle. And basically, it's typified by this progressive loss of right ventricular myocardium as replaced by fibrofatty tissue, which is the pathologic hallmark of the disease. So looking back at the history and why this is called ARVD and why we call it ARVC now is it was first described in 1977 by Fontaine et al. And it was basically seen in patients with drug-resistant ventricular arrhythmias with right ventricular dysfunction. So basically what his group found was that they saw patients with VT coming from the RV in origin. They saw RV dilatation, late potentials and left-sided extension, and this fibrofatty infiltrate on biopsy specimens. And this is kind of the first case series looking at 24 patients where they described this in the early 80s. So at first, it was kind of designated to be ARVD in terms of dysplasia because it was thought to be a congenital defect with development of the right ventricular myocardium. But subsequently, we've kind of found that disease is caused by genetic defects in cardiac desmosomes, which we'll kind of dig into a little bit more. And as kind of gained recognition, this is not a dysplasia, but in fact, that someone's born with, but in fact, it's a cardiomyopathy that develops, and it's been thus kind of classified by the American Heart Association as a cardiomyopathy. So basically now everything you'll see says ARVC, but in terms of the literature, you'll still see people write ARVC/D to try to encompass the fact that it was historically called ARVD. I'll try to be consistent throughout the rest of the talk, but you may catch me saying ARVD. So looking at the pathology itself, as we talk about, we see replacement of the myocytes by fibrous and fibroadipose tissue in the right ventricular free wall, as you can see here. Lesions extend from the epicardium to the endocardium, and we can see that based on the pathology. What's important to know is that fatty infiltration is not on the criteria for histologic diagnosis of ARVC, and it's really a fibrofatty infiltration because fatty infiltration is quite nonspecific and can be seen in multiple different disease processes. So this is just a look at an azan trichrome stain of a normal right ventricle and a pathologic ARVC case. So we can see that the myocytes in a normal right ventricle are stained red, but here, basically the entire right ventricle slice that we see here has been replaced both by the fibrous tissue, which is blue, and then interspersed with this fatty tissue, which is white, with near obliteration of the cardiac myocytes. So what we see in terms of the pathology is that we see this myocyte loss and fibrous replacement. It tends to be segmental and usually doesn't involve the interventricular septum. Historically, it's been called really focus on the right ventricle in terms of this cardiomyopathy because what's been called the triangle of dysplasia between the anterior part of the pulmonary infundibulum, the apex, and the inferior posterior wall. But what we've kind of now seen through further studies, and we'll talk about a little bit, is that there is involvement of the left ventricle often, even if there is not macroscopic evidence of LV involvement. So this is kind of a diagram looking at the kind of previous classification of this triangle dysplasia involving the RV outflow tract the RV base, and the RV apex. How do we identify this? Basically, it used to be just based on RV angiogram and histopathology. More contemporaneous model of looking at ARVC, we see that the right ventricular outflow tract and the RV base is involved, but in fact, probably the end of this triangle tends to involve more of the left lateral wall. And we've kind of found that by looking at electroanatomic mapping, cardiac MR correlation, where we see fatty involvement of the left ventricular lateral wall, echo correlation, and even cardiac CT. So kind of looking at a cellular level, what's actually going on. This is kind of the first shots of electron micrographs trying to actually determine what the actual pathology of this disease entity is. So this is the pathologic sample, and this is the normal sample. And for those of you that aren't used to looking at electron microscopy of cardiac myocytes every day, which I am not, kind of guiding you through it, here in terms of looking at the arrow, we see a widened gap of the fascia adherens. And what I take the authors at their word is saying that we see an abnormal position of the desmosomes with kind of an abnormal level of the myofilament lines in compared to what looks like a regular membrane, which looks much more ordered. Even someone who's not electron microscopist, I think I can kind of appreciate that. So kind of digging into the desmosome itself, what actually is made up in the desmosome. So the desmosome is a complex of membrane proteins that play an integral part of intercellular adhesion, not just in the heart, but basically in any tissue that undergoes mechanical stress, the heart, the skin, other beds as well. So the desmosome itself is made up of three main groups of proteins. So we have desmoplakin, which we can see here, and that binds the intermediate filaments, and so desmoplakin is also known as cardiac desmin. We also have transmembrane proteins, also known as desmosomal cadherins, and this, some examples of the transmembrane proteins are listed below. I'm not going to try to butcher the pronunciation of such. And then we have linker proteins, which mediate interactions between the desmosomal cadherin tails and the desmoplakin. So this is the diagram of a normal desmosome here. And as you can imagine, there is a nuclear regulation that actually encodes these proteins that makes up this normal desmosome. In terms of desmosomal disarray that we see in ARVC, basically interruption in any of the desmosomal proteins can result in desmosomal dysfunction. So basically impairment in the assembly of this genetically defective proteins causes the translocation, particularly of plakoglobulin, from the sarcolemma to the nucleus, which can actually antagonize the effects of beta-catenin. So there's actually a negative feedback loop here where if there's disruption in the desmosome, it can actually feed back to the nuclear control proteins. And so this can actually, particularly happens during episodes of mechanical stress. And then when you have, this competes with beta-catenin and induces a gene transcription which can switch from this myogenesis to the apogenesis and fibrogenesis. And that's thought to be one of the main drivers of why we actually see not just myocyte disarray, but actual fatty infiltration. So in terms of the genetics, we realize that there's not just one gene that actually confers this phenotype, but there's multiple different genes controlling and encoding for multiple different proteins that all affect the desmosome and kind of wind up down this common pathway. So all these genes that are important in cell-to-cell adhesion can play a role in pathogenesis. They typically tend to be autosomal dominant, but we do see incomplete penetrance, which we'll talk about in terms of the clinical presentation. But they tend to lead to an isolated cardiac phenotype, although there are specific syndromes which can involve ARVC, but also have other presentations in the skin and soft tissues, which we won't talk about today. But various mutations, including missense, nonsense, splice sense, frame shift, and large deletions have been reported, but they tend to be private mutations and tend to not be widespread. So desmosomal gene mutations have been identified depending on looking at the series, between a third to 2/3 of the probands of ARVC. And the most recognized and most common is this PKP2, which is identified in desmosomal genes. Looking at the genetics, we kind of realize now that we've talked about ARVC, but it is a spectrum. We're not just seeing that this affects the right, and basically it's on the same spectrum affecting the left ventricle as well. We tend to see more desmosomal and ion channel mutations affecting the right ventricle, with more cytoskeleton and more sarcoplasmic reticulum, mitochondrial kind of mutations affecting the left ventricle, but there certainly is overlap. So talking a little bit about the epidemiology of ARVC, we know it's an important cause of sudden cardiac death, accounting potentially for 11% of overall cases of sudden cardiac death in young adults. When we look back for patients that are diagnosed with ARVC, about 50% of patients can be tracked back to a positive family history. And we know that there's incomplete penetrance with limited phenotypic expression, which probably underestimates the amount of prevalence for familial disease. So even if someone inherited a mutation from a family member, they may be the actual first person to actually present with the pathologic phenotype, even though the genotype has been passed down from generation to generation. With the advent of genetic testing, and we'll talk a little bit more about the indication for genetic testing, we're now finding a large group of asymptomatic mutation carriers, and we're kind of trying to still figure out what exactly to do with these people. But the kind of cited penetrance, or the cited incidence, is actually 1 in 1,000 to 1 in 5,000, which is probably more frequent than I would have previously expected. So looking at the clinical presentation, initially when patients were diagnosed with ARVC, it was made in the presence of ventricular arrhythmia. This was the only way they really brought attention to clinicians. Affected individuals tend to present about in the second or third decade of their life. And classically, it was thought they present with palpitations, lightheadedness, syncope, and this ventricular tachycardia was caught originating from the right ventricle. So here's a series of patients from the Hopkins group that actually, looking at about 100 patients that were diagnosed with ARVC. 69 of them were diagnosed while they were alive, and 31% of them were diagnosed on autopsy. As you can see, people tend to present at quite a young age, at around the age of 30. It tends to be about 50% male. The actual racial component probably is skewed to some degree by different databases, but we tend to see many white people, particularly Northern Europeans, that present with this disease. And we'll talk a little bit more about people's involvement in activity, but people present, about 36% of people that present while alive with palpitations, 30% with syncope, 13% with dyspnea, about 20% with lightheadedness, and then 22% can be even asymptomatic, which is what we're seeing more and more of. So looking at the people that came in when they were alive, we have imaging studies. 30% can be seen having severe dilatation of the right ventricle. We also have left ventricular impairment with localized ventricular aneurysms. And this kind of is going to tie into our diagnostic criteria, but about 50% have some amount of EKG abnormalities. And then up to 77% were found to have some amount of arrhythmias. But you can see, in terms of family history, it can be quite variable, but only about 17% were found to have some kind of family history that was diagnosed based on biopsy or autopsy, which kind of accounts for both the fact that only about half of these syndromes are thought to be inherited, and then the penetrance is low. Similarly, looking at a population from 130 patients from a referral center in France, we see very similar age in terms of in the mid-30s, and also presenting with a wide array between palpitations, arrhythmias, dyspnea. So many patients can remain clinically silent and asymptomatic for decades, making the diagnosis difficult to recognize, particularly in sporadic cases without any familial involvement. And clinically overt disease can be preceded by a preclinical phase, which is kind of been characterized with minimal or no structural abnormalities, which is talked about being the concealed phase. And what's really the most concerning is that sudden cardiac death can be the first clinical manifestation of the disease. I think kind of talking about the fact that we use the right ventricular in terms of the nomenclature, but what we actually see looking at autopsy studies for patients that have had sudden cardiac death and were deemed to have an arrhythmogenic cardiomyopathy, we actually see a lot of overlap. So in one case of 202 cases of arrhythmogenic cardiomyopathy, only 13% had isolated right ventricular cardiomyopathy, 70% had some biventricular involvement, and 17% had left ventricular involvement. Just kind of going to show you that we are actually seeing more left ventricular involvement even when it's maybe subclinical. So there's not so much data in terms of progression of disease. What we do know is that affected individuals do not have evidence at birth. And typically disease starts to manifest clinically earliest at around age 12 to 13, but the mean age of diagnosis is in the 30s. So this is one small group that studied the cardiac function on repeat echo of 85 patients that had been diagnosed with ARVC. And what we can see over time is that the right ventricular fractional area shortening decreases over time. We can see that the left ventricle EF function tends to kind of, again, not be as clinically apparent as the right ventricular dysfunction. And you can see the right ventricular outflow tract enlarges over time, both in the short axis and in the long axis. So I think the best way to kind of talk about how to diagnose ARVC is just to go through the actual criteria and guidelines. So this comes out of the 2010 task force. And this really kind of came about because there is no one gold standard test to show us that someone has ARVC or ARVD. Even biopsy itself, as we see, can kind of be nonspecific. So I hope this projects well. But what we kind of see is that this has kind of been split up into major and minor criteria. And we have basically imaging modalities of echo, MRI, and angiography. And then we also have tissue characteristics in terms of biopsy. We have electrocardiographic activity, both repolarization and depolarization abnormalities, arrhythmias, and then family history. So I'll go through some of this to kind of elucidate more in terms of how the disease actually progresses and what we're actually looking for when we have abnormalities. So looking at the EKG, there's a kind of great variety of EKG patterns because what we're seeing is really a progressive loss of RV subendocardial fibers and conduction defects for those that survive. So basically the EKG abnormalities that we're seeing are both long and narrow activation paths, altered gap junctions with effect of the desmosome and among the fiber fatty tissues. So the amount of EKG alterations can depend on the extent and localization of the disease. And basically on different series that we see here, we see kind of widely different numbers in terms of what is the prevalence of these different EKG abnormalities and defects. So this is just one example of 10 EKGs and for 10 different patients with ARVC. And they can really range from anything from a normal QRS with some inverted T waves just in V1 and V2, the epsilon wave, which we'll talk about, right bundle morphology, that you really can see a lot of different defects, and that's because the fiber fatty infiltrate can happen in a lot of different areas. So looking first at repolarization abnormalities, the major criteria for EKG abnormalities is inverted T waves in V1 through V3 or beyond. And this is importantly in individuals greater than the age of 14 because we often see this juvenile pattern of T wave inversion in younger people that is not pathologic. And this has to be in the absence of a complete right bundle branch block because we'll often see these T wave inversions with the right bundle branch block. Minor criteria are that we can see inverted T waves in V1 and V2 in basically with the absence of T wave inversions in V3 or V4. Similarly, we have inverted T waves in V1 through V4, but they have complete right bundle branch block. So what is actually happening is this repolarization abnormality, as we see here, and we saw in the patient that I saw at Grady. is just the fact of the fatty infiltrate affecting repolarization abnormality. And this can potentially be seen in up to 87% of patients with ARVC, kind of depending on the series that you look at. However, up to 30% of patients in a different series had an EKG concealed form of the disease where there actually was no criteria that was fulfilled by the 2010 EKG criteria. So looking at depolarization abnormalities, I think epsilon wave is the thing that we always look for in terms of the test of suggesting ARVC, and we'll talk about that. But they're basically reproducible low amplitude signals between the end of the QRS and the onset of the T wave in the right precordial leads between V1 and V3. The minor criteria which we won't talk as much about are signal-gated EKGs that may suggest abnormality, and terminal activation duration, which we'll talk about. So the epsilon wave itself is this little notching that the arrow points at. It's a small amplitude distinct potential at the end of the QRS and the beginning of the T wave. And it's highly specific correlated, but however, it is really just seen in the minority of patients, and it tends to be seen in patients with pretty advanced disease. So this is what it looks like for patients with an incomplete right bundle, and just kind of this deflection here in the complete right bundle. So what does the epsilon wave actually show us? It basically, looking at electroanatomic mapping and correlating it to the epsilon wave itself, we've seen that it basically shows the timing of the epsilon wave on surface EKGs corresponds to the activation here in the basal or peritricuspid right ventricular region of the endocardium. So we kind of see the severe scarring, which leads to this conduction abnormality. But as I said kind of before, the actual prevalence of this in registries can range from 1% to 25% of patients with ARVC. In terms of terminal activation duration, this is something I hadn't really encountered too much before, but terminal activation duration is measured from the nadir of the S wave to the end of all depolarization and deflections. And it's called prolonged if it's greater than 55 milliseconds in any of the leads between V1 and V3 in the absence of a complete right bundle branch block. So this can kind of help, particularly in patients that are having VT, help us try to identify if this is coming from, if this is an RVO VT or a true ARVC VT. In one series, 30 out of the 42 patients with ARVC, with VT that had this terminal activation duration of greater than 55 were found to have ARVC, and only 1 out of the 27 had idiopathic VT. So something to keep in your back pocket. So as we see here, all differences in terms of EKGs can really kind of are correlated, as we know, to electroanatomic depolarization. So everything from the epsilon wave to the incomplete right bundle to the complete right bundle to this TAD just affects depolarization. I thought this was just a neat way to depict that. So going back and looking at arrhythmias themselves, when this was first identified, arrhythmias were the big thing that was actually pointing people towards ARVC. The major criteria is non-sustained or sustained VT with a left bundle branch block and superior access, thinking that it's coming from this area of the right ventricle. Minor criteria are non-sustained or sustained VT or outflow configuration with an inferior axis instead of the superior axis. And an EKG with just 500 ventricular exosystoles in 24 hours on a Holter monitor can be a minor criteria, although as you can imagine, this can be quite nonspecific. So when talking about ventricular tachycardia, as we know, it can range from just a few premature ventricular beats, to ventricular tachycardia or even ventricular fibrillation. And what we know is that the arrhythmias of ARVC are triggered or worsened by adrenergic stimulation, where we kind of see this fibrofatty scar. So VT, as we know, we talk about it coming from this area of this triangle of dysplasia. And quite often, we can have a difficult time distinguishing whether this is ARVC or it's coming from an idiopathic RVOT. So I want to talk a little bit about ambulatory monitoring, because often patients that have suspected ARVC have Holter monitors for 24 hours. So it's very important in terms of the diagnosis and characterizing the pathology of ARVC. However, I just wanted to kind of point out that there can be quite variability day to day in terms of patients that have ARVC, how many extra systoles, ventricular systoles that they're having. So in a study of 40 patients that kind of were already diagnosed and met task force criteria, they underwent about 5 days of monitoring with Holter monitoring. And they saw a pretty significant beat-to-beat variability from day to day. So this is the kind of the line of cutoff of 500 extra systoles. And there are some people that on one day, if you just took 24 hours, would not actually meet criteria. On other days, they would meet criteria. However, despite this, it was accurate about 89% of the time, just doing a 24-hour Holter versus doing the 5-day Holter. So in terms of imaging criteria, what we're really looking for is global or regional dysfunction and structural alterations by either echo, MRI, or RV angiography. So looking at echo, the major criteria are you need to first have akinesia, dyskinesia, or aneurysm of the right ventricle, and then one of the following, which is the measurements that we see in terms of enlargement of the RVOT in the long axis or short axis, or a fractional area change of less than 33%. The minor criteria, basically, you see less enlargement. So what's important is that histologic changes are not directly identifiable on echocardiography, but they lead to this macroscopic changes and regional wall motion abnormality. So the degree of RVOT dilatation and reduction in RV fractional area determine whether this is a major or minor criteria based on their specificity. So the criteria are very specific, but kind of lack sensitivity, especially in the early stages when RV dilatation and dysfunction are absent. And so there are several kind of evolving parameters since the most recent guidelines were written in 2010. But there are several parameters, including TAPSE, peak systolic RV annular velocity. They tend to be lower in ARVC, but these have not yet been kind of put into the guidelines. Something that is also emerging is looking at RV strain. A cutoff of -18 has been proposed to differentiate between normal and abnormal segments. And it can also be very helpful for looking at kind of subclinical systolic dysfunction, particularly screening patients in first-degree relatives. MRI itself can be quite helpful, and it's thought to be the gold standard. But we'll talk a little bit about some of the pitfalls of MRI. So initial studies were really focused on actually trying to find the fat in ARVC, looking at thin wall on T1 weighted spin images. But this is really kind of inconsistent and poorly reducible because we often can see fibrosis without too much fatty infiltrate. So looking at the direct visualization of the fibrofatty replacement kind of was had issues because they weren't able to directly identify the fat. The fatty infiltrate was very nonspecific, and we could see this in other disease processes. And looking at leak gadolinium enhancement, obviously this has a lot of overlap with non-ischemic cardiomyopathies. So the ARVC diagnosis really is looking at the consequence, again, of the fibrofatty displacement, just like an echo. So looking at static morphologic abnormalities like aneurysms or bulging, in addition to this dynamic process of akinesia or dyskinesia or asynchrony. And segmental combination of myocardial thinning, abnormal motion, and fatty infiltrate is in favor of fibrofatty replacement. Again, fat in and of itself is a non-specific finding. So the major criteria for MRI, what we're looking for is regional RV wall motion abnormality. As we say, kind of the interventricular septum tends to be spared, and then an increase in RV end diastolic volume, and either that or a depressed right ventricular ejection fraction. So these findings themselves have a sensitivity of 60 to 70% and specificity in the 90s. Here is just kind of an education based on patients that were found to have ARVC based on the entire criteria, looking at the sensitivity and specificity. And as we see, MRI tends to have the highest specificity in the 90s, but even all these modalities are not 100% specific for ARVC. This is where family history really comes in, because family history can be key. And so one of the major criteria is a patient that is a first-degree relative of someone who has ARVC, whether that's because of they've been confirmed based on the task force criteria, as we've kind of spoken about, or whether they've been diagnosed on autopsy, or identifying a pathologic mutation in a proband that's then been passed down. Minor criteria is first-degree relatives, so it's not possible to determine whether the family member meets the current task force criteria, but you have a strong suspicion that they actually did have ARVC. Again, if someone had premature sudden cardiac death less than the age of 35, since we see about 11% of people with sudden cardiac death have ARVC, whether it's or someone who has a second-degree relative. So kind of moving a little bit on to the most recent HRS consensus in terms of evaluation, risk stratification, and management of these cardiomyopathies. First, you kind of have to know who to suspect and who you're looking for in terms of ARVC. So people that have, particularly young people, that have exercise-related sustained palpitations or syncope, this has to be on your differential. The EKG abnormalities that we kind of noted, particularly in the precordial leads, seeing T-wave inversions in V1 through V3, which is what my presenting patient had. Someone who has unexplained frequent non-sustained VT or PVCs. People who present symptomatically or asymptomatically with ventricular tachycardia with this left bundle branch morphology in the absence of structural heart disease. That has to be under differential. Patients that have multiple QRS morphologies in VT that can be induced during EP testing, and survivors of sudden cardiac death, particularly during exercise. So the initial evaluation should cover some of the things in the task force criteria. So a clinical history is important. Physical exam, the family history really can be crucial. Looking at the 12-lead EKG, echo, and then a low threshold to send someone to cardiac MRI. If the initial testing is kind of non-diagnostic, you can consider genetic testing, the signal average EKG, which has kind of fallen out of favor. Looking at an exercise EKG can be helpful. Pharmacologic testing with isoproterenol, endomyocardial biopsy, or EP study. So looking at the criteria that we saw before, it can be broken down into definitive diagnosis, borderline diagnosis, or possible diagnoses based on the amount of criteria. For a definitive diagnosis, you need either one major and two minor, or 4 minor criteria. What's important is that these all have to be from different categories. So just because you have an abnormal MRI and an abnormal echo, that doesn't give you 2 criteria. There have been additional proposed modifications since the 2010 guidelines came out, looking at either high throughput sequencing, doing voltage mapping, gated endomyocardial biopsies, isoproterenol, speckle tracking. These things are proposed, and I assume that there will be an update coming soon, but right now we have the 2010 guidelines, which are as we spoke about. So in terms of the 2019 HRS recommendations, the first thing you really need is ventricular dysfunction, and that can't be explained by other causes. Then you have to answer the question whether an arrhythmia is present. And that doesn't need to be VT, but really any arrhythmia, including conduction disease, so any EKG abnormality, any atrial arrhythmias, any ventricular arrhythmias. Then basically they say that all of these patients have some type of arrhythmogenic cardiomyopathy, not just ARVC. And then you have to answer the question of whether another disease is present and ruling out other infiltrative cardiomyopathies such as sarcoidosis, myocarditis, Chagas, amyloidosis, before you can diagnose someone with particular cardiomyopathy. What's important to know is what else is on the differential and what can be a mimicking disease. So some of the things we spoke about, even athlete's heart, Brugada syndrome, and other real congenital diseases. So what happens to these people once they're diagnosed? Looking at the clinical course of 100 patients, I thought it was a very neat kind of diagram. They kind of mapped what happened to these people as they followed them. So of the 100 patients that we kind of spoke about before in the Hopkins group, 31 were diagnosed on autopsy. And these were patients that who had died either from VF and sudden cardiac arrest, patients that had other symptoms such as shortness of breath and dyspnea, and then had sudden cardiac death. So of these patients, 26 of them had VT, 22% of them had VF, some had other symptoms. In terms of treatment, some were treated just with ICD, some were treated with ICD and ablation, others were given drug therapy. However, very few of them that actually made it, that were diagnosed with ARVC while they were alive, wound up dying. Some were alive with ICDs, which was the plurality of them. Some had heart failure with an ICD, 2 were transplanted, and 20 were alive without an ICD after several years. This kind of is borne out by this Kaplan-Meier curve. Many of the patients had ventricular arrhythmias as they aged. That being said, few of them died of cardiac death after they were diagnosed. So looking at kind of the risk of mortality, how do these people die? At another, in the French group, looking at patients that were diagnosed at age average of 31, and 8-year follow-up, there were 24 deaths. The mean age of death was around age 54, with giving you an annual mortality rate of around 2.3. Most actually died of progressive heart failure, and fewer died of sudden cardiac death. And this is probably due to the fact that many of them had ICDs. So trying to predict who is at risk for sudden cardiovascular death can be challenging, and it's still kind of being worked out. But looking at that group, they saw that patients that had things that you'd expect, people that had syncope, people that had signs of RV failure, people that had presented with ventricular tachycardia, people that had LV dysfunction, all had much higher risks in a univariate analysis of actually having cardiovascular death than their comparators. Similarly, looking at patients that are at risk for just ventricular arrhythmias, patients that present with sustained VT or VF obviously are at very high risk for having recurrent VT or VF. Those that present with syncope are at higher risk than those that just present with palpitations and are asymptomatic, which we can kind of expect. So based on this, the guidelines are as shared decision making, which is always good, a class 1 recommendation to discuss with the patient about the risks and benefits of ICDs, particularly when you're presenting with patients that are generally very young. It's recommended, kind of going along with the rest of the guidelines, that patients that have suffered a cardiac arrest be implanted with an ICD. And even those that present with hemodynamically tolerated ventricular arrhythmias, it's a good idea to send these patients for ICD. So in terms of thinking about the decision to implant an ICD, coming down this pathway, patients that have had a cardiac arrest or sustained VT that's not hemodynamically tolerated, it's a class 1 recommendation to give them a device. Patients that have had hemodynamically tolerated sustained VT or syncope that's thought to be a ventricular arrhythmia, patients, it's still a class 1 recommendation if they have an arrhythmogenic cardiomyopathy other than ARVC to implant a device, the class 1 guideline. And 2A for patients that are suspected to have arrhythmia, syncope that was due to ventricular arrhythmia, or whether they had hemodynamically tolerated VT from a right ventricular cardiomyopathy. There are particularly pathogenic mutations we haven't spoken too much about that predispose you to having ventricular tachycardia that can be deadly, and those people are recommended, to a recommendation to get a device. For those people that have an EF left ventricular EF less than 35%, following the general guidelines, it's recommended that if they have class 2 or 3 symptoms to have an ICD put in as a class 1 recommendation. And if they have class 1 symptoms, again, it's kind of a 2A, following the general guidelines. And then looking at, for people that meet none of these criteria, there are other criteria looking at major and minor criteria. Major criteria being non-sustained VT, inducible VT on EP study, having an LVEF less than 40%, or minor criteria, including male sex greater than 1,000 PVCs in 24 hours, or having severe right ventricular dysfunction, it's reasonable to implant a device and these people who have either 3 major, 2 major and 2 minor, or 1 major and 4 minor risks. So for patients that have an ICD placed, you have to first look and see if they're having inappropriate ICD shocks. If they are so, beta blocker therapy is recommended. For patients that do not have an ICD, beta blockers are a 2A recommendation, although there are no randomized control trials looking at patients with ARVC and beta blockers. For patients that are having symptomatic arrhythmias, MEO and sotalol, again, no large trials, but they're reasonable to reduce ICD shocks. And you can consider either ablation or adding additional antiarrhythmics. For patients with RV dysfunction in symptomatic individuals, you can consider ACE ARB beta blocker along with the current guidelines. Again, nothing has been particularly studied in these patients. The one thing that we really talk about is to restrict activity, and why do we do that? This is a study looking at patients that were diagnosed with ARVC and how their actual survival from first sustained VT. And this is looking at non-athletes, and in the green is athletes. So this is probably, along with HOCA, maybe one of the only cases where we tell our patients not to exercise, and that exercise can really be deleterious. The real question is why. Looking at competitive sports, we see a breakdown between the black here being competitive sports, red being recreational sports, and blue being inactive. And we see actually in this study looking and breaking down between competitive sports and recreational sports, the recreational athletes tend to actually be tracked closely along with inactive patients. And we think that really has to do with stress on the cardiac desmosome and the negative feedback loops that we talked about. So patients that meet the diagnostic criteria for ARVC, it's a class 3 to actually participate in competitive or high intensity sports. And for patients that have a genotypic positive family member that don't actually express the ARVC phenotype, they should be counseled to kind of avoid these endurance sports as well. In terms of family screening, it's important. Looking at one study outcome data from 274 first-degree relatives of 138 ARVC probands, 96 or about 35% of the relatives were diagnosed with ARVC. Looking at what actually conferred the most risk is that siblings had a 3-fold increase of ARVC compared to parents and children. This is thought potentially there may be other confounding genetic abnormalities that are contributing to the phenotype being expressed. And then looking at an average of 6.7 years of follow-up, 8% of relatives with ARVC experience a sustained ventricular arrhythmia. So it's recommended that patients have cascade screening with a 3-generation pedigree, and that they should undergo cardiac evaluation, including an EKG and cardiac imaging, and that they should undergo screening every 1 to 3 years after the age of 10 to 12, because again, this does not present at birth and can develop starting at the age of 10. Going back to our case, I referred my patient that I saw Grady to the heart failure clinic, and she saw Dr. Bott. Dr. Bott got an echo, which had the fantastic images we saw before, and got a Holter monitor. The Holter monitor demonstrated 18% burden of PVCs, so about 34,000 PVCs over 24 hours. Some short runs of VT, the longest being 10 beats. Some images to kind of clue us in on looking at what we're seeing. We see the RVOT measuring at the greatest is 33 millimeters. The right ventricle ejection fraction estimated at 34%, and the LV EF measuring at 46%. They got great pictures of her RV strain, and her RV strain was severely abnormal with a global strain of just 3.6. And you can see, I think this really helps us see that there are several areas of the right ventricle that are akinetic. Her echo readings are kind of as we discussed. And looking at her specifically, we see that she meets a major criteria in terms of imaging, both on echo and MRI. She has the repolarization abnormalities. This is a major criteria where she had the inverted T waves in V1 through V4, and also had greater than 500 ventricular extrasystoles in 24 hours. She was referred to Dr. Lloyd and is going to follow up in the EP clinic for consideration of device implantation. Thank you.
Thank you, Evan. A very good review. I wanted to clarify something you said, though, about exercise restrictions and hypertrophic cardiomyopathy. There are certainly a lot of similarities in what we recommend for these patients versus those with hypertrophic cardiomyopathy. As you mentioned, they're restricted from competitive participating in strenuous competitive athletics or very strenuous recreational activities like running marathons or triathlons, things of that nature. But a subtle but pronounced difference, as you mentioned, is the sort of thought that continued sort of high level, even recreational activity can cause a progression or worsening of the phenotype of this disease, which is a distinction from hypertrophic cardiomyopathy, which has never been shown in hypertrophic cardiomyopathy.
Absolutely.
So, I would say that we're probably a little bit more, I certainly am more restrictive in terms of exercise recommendations for this group of patients, where I would sort of restrict them more to light activity. Again, that's not necessarily 100% data driven. It's more just sort of mechanism theoretically driven, sort of lighter activity versus my hypertrophic cardiomyopathy patients. I do, and there have been studies in patients with hypertrophic cardiomyopathy that moderate level activity is safe and probably overall beneficial for them in the long term versus in this group, again, we'd probably restrict them more to sort of activity on the lighter end in terms of the exertion level, how strenuous activity they're going to do. So again, just a subtle difference, probably a little bit more restrictive with this condition, again, because of the phenotype. Well, another just quick point, interesting sort of historical point about this disease. A lot of the controversy that exists in terms of recommendations for sports participation, athletic participation, and the differences between the Europeans, mainly the Italians, that have really been the drivers of very aggressive testing for athletes in terms of imaging, echo for everybody, et cetera, EKG for everybody. It probably has to do with this disease. Italy is one of those places in the world that is highly susceptible to founder effect in the sense that you've had the same people living in the same little villages and valleys for thousands of years in Italy. So one sort of particularly malignant mutation can get in a group of people in Italy and wreak havoc. And that's probably what's happened in the sort of northeastern part of Italy, where they have a high prevalence of this disease. And if you look at Italian databases, they have a much higher rate of, I don't know about much higher, but they tend to have a higher rate of sudden death in their athletes than pretty much anywhere else in the world. Yep. Thought to probably be due to this condition because the rates of hypertrophic cardiomyopathy seem to be the same in Italy as they are in the rest of the world. So this has played a role probably in the Italians having such strict guidelines for their athletes, and then the Europeans adopting some of those as well. Yeah, I guess I don't have any questions, just a couple comments, but anyway, good talk.
Thank you.
The other thing I would say is you have to be careful a little about your EKG reading. Flip T's in V1, V2, V3 are what is known as a persistent juvenile pattern because juveniles tend to have this. And it's also interesting that you can see women from the Caribbean area that will have flip T's and otherwise normal EKG out to V4. So it's an interesting thing, and I don't know if anybody talked about it, that it looked like there's a big overlap between the EKGs on some of these people and what you saw in normal juveniles.
Yes, I'd agree. So I think the guidelines make note first that this cannot be applied to people under the age of 14, particularly for the juvenile pattern. And in the guidelines, I think there is a mention that people of African descent, you have to be careful in terms of that they can have persistent patterns, but it should clue you in. But that in and of itself is not diagnostic. It's a minor, one of the criteria, but still needs to go along with echo imaging or some type of imaging to actually show that there is ventricular dysfunction. So I'd agree. It should clue you in and should maybe potentially prompt further investigation, but is not pathognomonic in the way that, say, an epsilon wave is, or things of that nature.
Yeah, I don't want to speak for Jonathan Kim, but I can tell you that that particular EKG pattern is a very frequent reason for referrals to him and,
Yep.
you know, high school, college athletes with that sort of persistent juvenile pattern.
Yep.
And you're right, and sometimes it can be very difficult, and particularly in a highly trained individual who might have a little bit of RV, dilatation on echo, et cetera.
Yep.
I know it's led to probably some consternation for him and others, but you're right, you have to be very careful in that because it can be a relatively non-specific finding.
Thank you.
The preceding program is copyrighted by Emory University.